I'm honored to present our first live transmission. Here, I would like to introduce my team here. Is my co-director, Dr. عويد الشمري, Dr. Sharif Zaghloul, our IVAS commentator today, Dr. Stéphane Crier from France, and my team here, Peachy, Cathy, Hani, and everybody here. So I will let Dr. Awayed present the case.
The first case is a 52-year-old gentleman who has a BMI of 30, diabetic, hypertensive, had PCI to LAD, high diagonal and left circumflex 3 months ago. He's actually was referred to surgery but declined surgery for a good 2 years before
Yeah, yeah.
he commented to multivisible PCI last October. But the occlusion from the almost the proximal segment till the distal one.
Okay.
So this is the first injection to the left system, checking out the previous work, patent stents. Um, Next, and here you will see that the occlusion from the proximal RCA till the crux with some microchannels open here and there throughout the occluded segments. Next. So here the antegrade injection. And as you see here again, confirm the findings. There is occlusion also on the BDA, mid BDA. It can be the competitive floor from the PLV going to the PDA, or it can be the true total occlusion. Next. So Khalid started first with the microcatheter and
Yeah. Fine cross microcaster and further XTR. We try to negotiate for, because we know that the lesion is not so long and the calcification, it's maybe it's a mixed plaque between the calcification and the fibers. So we believe that we can negotiate with a filter XTR as the first wire, of course, antegrade. And of course, we have another plan for pull-out techniques for retrograde, but I let the Dr. White continue what we are growing. Yes?
okay, so if you can see the other view, this is the lateral one or the LAO,
Yeah, can we put the pipeline,
or
please?
this. If you can see the biplane. So as you see here, the both the views showing that we are in the true lumen so far. Next. Then making sure that we are in the channel. There is maybe a branch just at the tip of the wire in the area or the AP cranial or areocranial view. Next. So the wire went to that branch. So now we are sure we are in true lumen. Here where we are right now, and Khalid trying to negotiate the wire directed toward the RCA.
So I
So
think we can we have another. So I start with a filter again and going to the other branch. So can we have a test, please?
okay, antegrade.
No, retrograde.
That's okay.
We are outside, so I can go because patient has some plaque in the left main, and this is a 7 French, so it's very safe. Can we move the table, please? Very safe, just to take care all the time for your donor artery.
Yeah.
Okay. Can we have a AP, please? AP, please.
Good.
Okay. Go again. Okay. The pressure is ventricularized with
Okay,
I
just
think
hold on a little
we
bit.
need to check the left main, huh? Okay, test. Okay. Yeah, because it's film in French. Okay, yeah. Okay. Film.
Yeah. Okay, you can
Okay,
disengage a little bit.
the pressure is ventriculized in the left main. I think after we finish, we should check the left main with IVUS.
Okay.
So I think he has a calcific plaque. So that's why we need to have penetration wires. But I will try again with a Felder XTR. But just to put to for security to secure the left main. Give me AP, please, Ernie. Okay.
Yes.
Yes. So I think we passed the most, some of the good area in the CTO area. Yeah, yeah,
Yeah. Yeah.
yeah. Okay, okay. Give me a guiding. Yeah, I don't hear you. Can you? Yeah, I hear you. No, no,
Yeah. Good. Okay. Okay. This is what we will do. Sure.
already prepared.
خلاص. Okay. Yeah. This is it. Okay.
It's a 7 French. Yeah. Of course, with no side hole, because otherwise we'll lose this sign that the left main has problems. So we don't put a side hole when we have a disease left main. Otherwise, we have a fake pressure. So I take it's your suggestion to put a wire in the LAD or in the circumflex or whatever.
Yes. Good. خلاص. Okay.
I prefer to put to have this wire, Dr. Walid, there for more secure, and then we'll negotiate a little bit with with the filter XTR, and if it's not, so here's the CTO segment. My wire going somewhere.
So this is the time for Gaia.
So I think we have to check the next the retrograde. Yeah, yeah, yes, of course. So we'll do a retrograde injection.
One second. Yeah.
Yeah, without I will do without injection, please. Okay, yeah, injection. Yeah, nothing appear, but
Okay.
anyway, we can see
Okay.
that I don't know. I'm under the calcium, but the wire is going. So I don't know where it's going, but
Yes.
yeah, that's why. Here my wire is stop moving. Yeah, I try because it's a maximum microcaster can go.
It's a maximum.
I think so.
So it needs more penetration power here. Yeah.
Yeah,
It's getting something. Yeah. Yeah. Yeah.
yeah, yeah.
Yes.
Okay, we take a REO cranial, please. Give this one cranial, yes. Okay. Okay, the wire movement is not that bad. No, I don't think it's a good option to advance microcatheter, but maybe this in another branch or in the false lumen.
I think it's facing another occlusion. Try to get the microcatheter inside. Now we have some purchase of wire in front of it.
Yeah. I don't want to. Yeah.
Yeah, yeah,
The microcatheter going smooth, huh?
yeah. Yes, yes.
So I think here we can take another wire just to.
Yeah,
Yeah, okay.
yeah,
Yes,
yeah,
yeah, we are
yeah.
absolutely. Okay, give me a lateral view. Okay, injection, please. Okay.
You know? Yeah.
Yeah. Looks like here's the RCA, but I need a stiff wire. Okay, so give me the Gaia, please. 'Cause,
30. Not bad.
yeah, will not stay more time. Yeah, the radiation is high. Okay, so the microcaster cannot be advanced more here.
It needs more purchase, wire purchase.
Okay, so I
But
take the Gaia.
But if we do that, we burn the possibility doing antigrade injection for testing.
Yeah, two.
Do you like it to be lateral?
No, you can go to
Reduce the LAO, the lateral, make it LAO, please.
heliocranial, helio,
Okay.
normal helio. Okay, so I think
What is
it's
that progression now?
yeah, but I don't know where we are
Okay,
because I
we'll go.
think we are still in the branch.
Okay.
Okay, can you give a yeah, it's in the branch. So I'm close.
But this is it.
Yeah. I know. Yeah. I saw it. Can you see it? Maybe we are a little bit up and directing upward.
Yeah. Yeah.
Oh, yeah. Okay, so I think I'm in the false lumen because it's I get when you have this friction with the pulling wires, so I think it was the false lumen.
Actually, this is unique for Gaia. I noticed when there is a calcium, um, it can um, stuck to it and may unravel if we pull it. So we need to rotate the opposite the last movement in order to free the wire from the calcium, not necessarily to be in the.
Yeah, I think you are correct, Dr. Khaled. Then I need a second curve to go here because we can see by calcium, but as you see here, the Gaia is already broken. Okay, so we still with the Gaia 2, but Gaia 2 is broke. Yes, I changed now with Gaia 3.
Okay. Okay. So you want injection?
Oh, yeah.
Any or no?
Okay.
We need pipeline. Sini. Sorry. Sorry. Next. Okay.
See,
Yeah.
that's why I understand. See, I would like just to go with the calcium there.
Okay. Good. Okay. Okay. Okay.
No, it's out.
اصبر. Floor off. Floor safe. Floor safe.
You cannot save here for.
Oh.
Okay. No, but I'm out here. Wait, I'm not in the
Yeah.
calcium.
Another branch. You're at another branch. Yeah.
Here, this one. I would like to puncture this one. Okay, this one.
Why can't you
Okay,
fluoro
can you?
save this
No,
one?
no, but okay, okay. Just give me a
Okay. Right.
contra the injection.
Right. 1 second.
This one much better. Then it was not able to pass, so we agreed together to take Gaia second.
Next.
Again, Gaia second cannot pass,
Next.
and the damage 2 times. Then I change with Gaia 3. So I will let you see all the, where we are. So all the time when I negotiate, my wire is going to side branch, maybe the second RV branch, and always in this place, this is the RV branch as you see. So in this place, I believe there's a big calcium burden as we see in the CT and second CTO segment. So I agree with Dr. Awaid to have a more puncture wire, so penetrating wire, which is Gaia 3 or Conquest Pro. So we take a Gaia 3 was not working 2 times, and you see here we are outside the artery. As you see here, so we are totally outside the artery.
Just let me fill down.
Next.
Sorry.
So I redirect again with the guy as I'm again totally outside the artery. So I would change with Conquest Pro 9,
The one, yeah.
which is penetrating the artery, but it's going also sometimes outside. So I believe the changing projection is very important. This step just to understanding the course of the artery. Here next.
Yeah.
I don't know. I don't think so.
So I negotiate again with Conquest Pro 9, and it was no discussion between me and Dr. Awaid just to change with a more hydrophilic wire. But I believe if the Conquest cannot go, otherwise cannot go as well. So it's here we are almost reaching the true lumen. We puncture the artery. Next. We change the direction. So it's here, maybe it's going to the small branch next.
Where is it going? This one is going somewhere different.
So reaching the BLV here, that's good. So we pass.
We know that
so
if we go through this part,
I will put my wire again to BDA.
yes, fill, yes.
And I pass the second CTO segment. And finally
So
we
this
finish
goes
the
from
artery,
different vessel. Okay, let's have
crossing
this one there.
the lesion. And no, it's here. So we are here now. I will show you. Our wire is here now. The microcaster is stopped in this part in the big calcium burden near the cracks. So I believe I will do a small balloon inflation in the mid-segment RCA, and we check with IVUS. And then if we are in everything is good, we are true lumen, we change and we dilate. So what do you think?
Excellent. That was very impressive wire manipulation.
We need pressure.
So I will let Dr. Awaid just summarize what we did.
So we, after crossing, we left you with crossing of the lesion using the Conquest Pro. Then we tried to do the IVUS, but it was not passing. Then we pre-dilated it with 125, was not passing. Then, the IVUS. Then we used 2O preparation balloon in order to do IVUS. We did IVUS study, and I don't know where Stefan can talk to you about the IVUS.
Can we bring Stefan here? Okay, go.
So I can tell you what he told us. He told us that the BDA is 3O luminal diameter, the adventitial diameter, but the lumen may be 2.5. Then, but the vessel itself is 3.5 and proximally 4.0. We were in a true lumen all way over the course of the wiring. Then Khalid decided to do drug-coated balloon to the BDA
Second place.
CTO. So it was prepared again with the 2.5 balloon. Then sequent balloon, we used it 2.5 by 30 for 45 seconds using the nominal pressure. Then we reduced it to the 6th atmosphere. They were prepared to discuss with Stefan regarding the sizing of stent. Do we need to involve the cracks or not? We don't want to end up with the metal jacket. While we are discussing, the blood pressure dropped. It's important to note that we removed the EBU guiding from the left main system after we cross the CTO. So it was 30 minutes ago. Is it related to the balloon dilatation, prolonged balloon dilatation of the BDA? Is it because the left main compromised? We don't know. So we'll do the left main later on after we fix the job in the RCA. as well as the patient is responding to the supportive measure. We give him IV fluid wide open, and we give him also a Levofed.
So we put
The segments of the stents look good, but
yeah,
there's the question of the crux
yes,
Exactly.
and
yeah,
the
yeah,
ostium, which
yeah.
doesn't look good.
Okay, so
Yes.
we see it by IVUS. So I tell Stefan, I would like to avoid to touch the cracks. So maybe there's not a.
The PDA is the big artery.
Yes.
I know.
If you don't touch the crux, you leave a high-grade lesion there.
Yeah.
I don't see any reason not to touch the crux. What is the opinion here? Yeah, the PL is not so big.
So we may secure the distal artery with a small stent, the 30 or 2.75. Short one is 15. Just secure the crux area. But I don't want to put to distal to the BDA. Already has inflated with a dragonutic
80
balloon.
millimeters of stent. So to discuss now full metal or not.
Ah,
Yeah. Yeah.
yeah, but actually I'm satisfied.
18.
Yeah, yeah, I'm
3 or 10.
no. It's we can have a 15, no, 15
Ah,
or 12.
3 or 15, I mean.
Yeah.
I think, Khaled, what you're referring to is that with CTO, sometimes things do improve. This lesion,
That's what I want. What I want to say. Yes, it's
you're not trying to avoid the metal jacket because you already have a metal jacket. It's just because it may improve. So the
yeah,
result will be
pause.
both.
Yeah, both sides. So sometimes I just doing a distal artery with a drug-eluting balloon, and we have a good result with this. Just stent CTO segment, and then a distal artery. I believe the damping of the pressure, as Dr. Awad say, but the guiding was deeply engaged, and this because
Yeah,
of
yeah,
the
massive
ostium of
all
the
the time.
RCA. So that's why we get some damping of the pressure. But patient now is very good.
Make it 18.
So
18. Make
yes,
it 18. Do you have 18?
Is
Yeah.
that plaquette crux or not?
yes, in screen.
So you have a couple of measurements on the longitudinal pullback.
This
In
one.
the same time, we are starting the pullback this very distal right.
Can you focus on the crux? Because the other thing is already stented. The question is now the crux.
So, so this is where we are distal to the crux. And you see that at this level there is some plaque, but the disease is not major and could be left like this. We are coming with the crux just at this level, and you saw that plaque burden is in the order of 50%, but all this segment here is acceptable. So now we will go back just around the crux. So we go more distally, and this is where we are entering in the distal right. So
So if there is not so much blood, then it should be even by a low pressure dilatation.
yeah, I
We already
agree.
did.
If the vessel is good, then you can get away with some.
We already have
Yes,
it.
this one. No.
Okay, so I believe to just to put a stent, ostial stent, according to the IVUS, and then we will follow up the patient. So we already have a low pressure, low balloon dilatation there. We have a drug-eluting balloon distally. So I believe it will improve.
You
Okay.
see the very proximal right, that is a huge vessel of 4.5, and all this has been stented, but all the way up to the guiding where we are arriving here, you see that there was a lot of plaque burden, and this is the guiding, and you see the guiding sits in the plaque.
Okay, so the ostium. So thank you, Khalid. We'll switch to Omer. He wants also to present his case. Omer?
Okay. Thank you.